For the last 20 years, minimally invasive kidney stone surgery has all been about the stone. And we ignore the papilla. We ignore the birthplace of the stone. And we may be missing out on a lot of information that could potentially help the patient in the future. Most kidney stones are, I would argue, the endpoint of a variety of different diseases, and we lump all of our patients together, but they may actually be quite different from one another. And even when we do have the stone for analysis, we know that stones are often of a mixed composition. So if we grab the piece or study the piece that was calcium oxalate, we may miss the small component that was uric acid. So depending on which piece of the stone we grab, we could be coming to false conclusions about what type of stone former that patient is. The other way we commonly characterize patients is with a 24-hour urine analysis. And if you have ever ordered one or been asked to do one, it's not the easiest test in the world to complete. It requires a compliant patient. It also requires somebody who's interested and knowledgeable enough to interpret the results, which is not always easy to do. So it would be very useful and helpful if urologists had a tool or a system or some way to better characterize patients in real time. And one way that we might be able to do that would be by what we see inside the kidney. I really can't take credit for this idea. I was inspired, by my fellowship mentor, Dr. Jim Lingaman. It can be very obvious when you start looking at the renal papilla that not all patients are the same. Some people have pretty profound papillary disease, a lot of plaque, flattening of the papilla, a lot of ductal plugging. And my suspicion is that this correlates with stone activity. And it's very possible, if not likely, that this can be an indicator of an underlying metabolic disturbance, a higher risk of recurrence or disease progression, and possibly other features as well, like coexisting renal dysfunction or kidney insufficiency. So here's a kidney, and this is commonly what we do at the beginning of any stone procedure. We'll take our scope, preferably our digital scope, and we'll just march out and map out the kidney from the top to bottom. And you can see that these are the renal papillae. And at the center of the papilla, you see that kind of white-colored, kind of snow-covered mountain appearance. That's plaque. And in most people, that won't be present. In a normal person, we won't see a whole lot of plaque. And generally, this goes along with stones. And in some cases, commonly you can actually see stones attached to the plaques. Here's an example where we actually pulled a stone off, and if you actually look at the undersurface of where that stone was attached to, you see a little ulcer or a little pit, and that's the site where the plaque actually came off with the stone itself. So this is a very classic example of a stone attached to a piece of Randall's plaque. So you definitely can see Randall's plaque easier than you can infer it. So it's a lot easier to know if someone's a Randall's plaque stone former with a picture than a 24-hour urine, because a lot of people who have abnormal 24-hour urines will not necessarily have plaque. Vice versa, if you look in some patients who don't have a history of a kidney stone, you will see some plaque, and that doesn't necessarily mean they're a stone former. But in general, high surface coverage of the papilla with plaque seems to correlate with stone activity. Ductal plugs, on the other hand, tend to be more expression of disease. You tend to see a lot more mineralization underneath the surface of the papilla, and commonly you'll see these dilated ducts. And these are actually the ducts of Bellini, and upstream from here, where urine and fluid alone used to be filtered, the ducts have been occluded by mineral deposition, and you actually see stretching of the duct distally, and so that tends to go along with ductal plugging. We don't typically see that in most patients. So when I see a lot of this, I'm always worried about a metabolic correlate, primary hyperparathyroidism or renal tubular acidosis, or something that is driving a heavy degree of underlying mineralization in the kidney. These patients tend to be very aggressive and rapid stone formers, and frequently will find a metabolic reason that goes along with it. The plaque kind of has that thin, shallow appearance, whereas a plug can be quite profound, and it can be bulky and creates much more of a anchor, so to speak. You can actually see the different minerals have a different appearance when you look at it under this micro CT, and you can start telling differences in where the different minerals sit in relation to each other. And you can also get insight into the structure and form of the kidney stone, which provides a lot of insight into how that stone might have formed. So here you can see this is the plaque, and the plaque tends to be calcium phosphate, which is a brighter mineral on micro CT than calcium oxalate, which is this darker gray. And you can see how the plaque is basically the stem or the anchor of the kidney stone, and once it eroded or got exposed to the urinary space, calcium oxalate grew on it, and that's what led to the stone forming in the first place. If you look inside a lot of kidneys, you often see mineral under the urothelium that's more yellowish colored. It tends to be more concrete, like full deposits of mineral, and we call these ductal plugs. And if you biopsy them, unlike plaque, which has kind of a thin layered structure, plugs can be big concretions of mineral that extend deep into the tissue. And we also have research to support the fact that this is a different mechanism that stones can grow from. I think we're just starting to make sense and scratch the surface of what we're seeing inside the kidney. And one of the biggest limitations is that we all can tell normal from abnormal, but coming up with a way to describe those abnormalities is very challenging. So we need a system to make sense of what we're seeing. The other important element is trying to match, what we see in the kidney and make sure that there's relevance to it. When we see something in the kidney like a lot of plaque or ductal plugging or surface pitting of the papilla or flattened papillae or any number of findings that we may see, does that have any clinical relevance?